Thank you for the kind introduction. President Patel, President-elect Tam, Executive Director Hume, dear colleagues and friends, thank you for the honor of allowing me to give the 2023 Dotter Lecture. Congratulations to the award winners this morning, Tom Sauce, Kurt Bacall, Zeev Haskell, and Jim Caridi. Teresa and Angela, I know that he's watching us right now. I would also like to thank the FSIR Foundation for supporting the Dotter Lecture. I would like to thank first and foremost my family, my wife Kate, my son Nick, his fiancée Gia, along with my new granddaughter are here today. My daughter Gabrielle, my son Nate are here. My dad is here too. Thanks for coming, Dad. We have 4 generations of my family here today. Thanks for being here. I love you all very much. I would like to thank my partners for allowing me to do meaningful work every day with people that I admire and respect. This is an amazing gift that I get to live every single day. I would also like to thank the talented and dedicated team that enables us to take care of our patients every day, our technologists, our nurses, advanced practice providers, administrative associates, medical assistants, schedulers, patient care coordinators, and countless others. And lastly, I would like to thank all of our trainees, our residents and fellows who work with us every day and hopefully learn a little something from us. You help us to be our best every single day. And apologies for the not so subtle photoshopping of Sarah into this picture. I'd like to dedicate this lecture to my brother Bob, who passed away suddenly at the end of last summer. If you knew my brother, you would know this is a strange choice by me to do this, because I've never met a physician who cared less about society, politics, and awards. But I do this to get back at him for leaving us too early and to make him listen to me one more time. So I'm the 39th person to have the honor to give this lecture, and I'm fairly certain that I'm the only person chosen by his or her partner. Thanks, Parag. I'll take it any way I can get it. Charles Dotter is rightfully called father of interventional radiology, and as with most prior colleagues delivering this oration, I feel obliged to say a few words about him. His total contributions are way too numerous to detail here. He famously performed the first transluminal dilatation of a peripheral arterial stenosis in 1964. In 1969, he published the original description of an intravascular stent. In 1972, he described both embolization for GI bleeding as well as intraarterial streptokinase administration for thrombolysis. In 1975, he described the use of cyanoacrylate for embolization. And in 1978, he was nominated for the Nobel Prize in Medicine. I'd like to thank Cook Medical for giving me permission to show this short video, which is narrated by Dotter himself. Many of you have seen it. I've watched it about 50 times now, and it never gets old for me. Here we go.
This man is in pain. All right, let's get started. Now the smaller inner catheter goes in and is advanced over the guide and down through the narrowing. Usually there's little resistance. Because of its safety, simplicity, and effectiveness, transluminal dilatation now qualifies as treatment of choice in the management of atherosclerotic stenosis. Its further improvement seems inevitable.
Its further improvement seems inevitable. I think he was right about that. So not only was Dotter a visionary physician, he was a Renaissance man. He was a talented artist. He was a classical music aficionado, an avid bird watcher. He climbed all 67 peaks in the U.S. over 14,000 feet, and he loved to drive fast. And I don't know who took this picture, but it was of Dotter getting a speeding ticket. It almost looks like it's staged. He looks so comfortable with the whole situation with his foot up on the bumper of the squad car, and he kind of looks like he's giving the deputy a couple tips. I'm not really sure. Dotter's mind was always at work trying to find solutions to the problems he saw around him. In this letter to one of his fellow bird watchers, he wrote, "Maybe I'm not up to date, but why not suggest to one of the condor preservation crew that they fix the lip over which the last 2 condor eggs have rolled to crack on the rocks below. A bit of rock cemented across the edge could keep some possible future egg in place. Maybe it's naive, but at least it would put gravity on the side of the condors, And if they do it and it works, they owe us a guided sighting." I'm grateful to Fred Keller for taking some time to talk to me about what it was like to work with Charles Dotter. These are a couple of excerpts from Fred's 2000 Dotter lecture. Similar to his cars, Charles' mind was always operated at full throttle, often working in several diverse directions simultaneously. Yet despite this apparent shotgun approach, he had the uncanny ability to clarify and crystallize his thoughts. And I love this one. Charles was a live wire. While life with him was not always shocking, you can be assured that it was never dull. Unfortunately, Charles Dotter had many health problems. He never fully recovered from a 12-hour redo coronary artery bypass operation and mitral valve repair that was performed by Dudley Johnson in Milwaukee in 1983, and he passed away in 1985. That same year, we lost Melvin Judkins, Andreas Grunzig, and Mason Sones. And after his death, Leonard Laster, the president of Oregon Health Sciences University, said, "Rarely in the course of a medical career is an individual granted the opportunity to alter forever the course of medicine for human good." Charles Dotter was one of those happy few. So, I'd like to fast forward now from 1985, when Dotter passed away, to 20 years in the future, in the year 2005. And the specialty that Dotter had founded was at a crossroads. I was on the FSIR Executive Council as education counselor at that time. Oops, didn't mean to do that, sorry. Many institutions had lost their peripheral arterial practices to vascular surgery, cardiology, or both, and there was a lot of angst going on about the future of interventional radiology. And at that time, we learned that on the Society for Vascular Surgery program in 2005, there was an entire session on embolization. And we sent a delegation of FSIR representatives, not as official guests of SVS, but just to go and listen to what was going to be said. And because this lecture is intended to be published in some form, I will not repeat what was said during that session, but suffice to say that it was disturbing on multiple levels. You can tell that these sentiments were on the minds of a number of the Dotter lecturers in the late 90s and 2000s. The very first Dotter lecture I attended was Barry Katzen's. His title was Endovascular Grafts, the Beginning of the Future or the End. Ernie Ring's title was Will IR Survive into the Next Millennium? Gary Dorfman, Revolution, Evolution, or Extinction. And Andy Adam, IR, Veni Vidi Vanished. I ran across this photo as I was doing my research for this lecture, and I just had to figure out some way to work it in. There's 3 Dotter lecturers on this picture, Barry Katzen, Jim Beninati, and Gary Becker, and I think they look like the Rat Pack of interventional radiology. So time passed, and IR did not fall into the abyss or even fade into obscurity, and the tenor of the Dotter lectures began to change. Fred Keller, title was New Paradigms for the New Millennium. Matt Morrow talked about the birth of a specialty. Jim Beninati's 30 Miles East of Samar was a positive message of cooperation and creativity. Scott Triotola urged us to become competitors, and Mike Darcy talked about IR training in the pursuit of excellence. So where are we now? IR has survived the somewhat uncertain time 15 or 20 years ago, and I believe that the current state is described by l'embarras des richesses, the embarrassment of riches, as we've expanded rapidly into new domains in interventional radiology. So we are unique across all of medicine that our foundation is doing minimally invasive procedures with imaging guidance. We're not based on an organ system like cardiology or nephrology. We're not based on a group of diseases like allergy or rheumatology. We're not based on clinical groups like geriatric or palliative medicine. And literally, interventional radiology as it is today is a mutual fund of medicine. And the commonalities are that we are cost effective, we allow our patients to have a high quality of life, and unfortunately these techniques are still underutilized throughout the world. Imitation is the ultimate form of flattery, and another measure of our success on the impact of medicine is the proliferation of other interventional subspecialties. And similar to this dissemination of ultrasound, we cannot and should not prevent the adoption of interventional techniques into the broader medical community. I'm hoping that in the future there will be interventional speech therapists who can place their own G-tubes after a failed swallow study, and that there will be interventional dialysis techs who can declot a dialysis graft when one shows up in their clinic. So let's take a look at the expansion of IR practice domains a little further. In 1996, when I finished my training and started practice, this was the footprint of interventional radiology. We were doing peripheral vascular disease, some venous access, biopsy and drainage, some non-vascular work, a lot of work with transplant, some diagnostic angiograms, and some very early intervention, and the first TIPS procedures are being done. As we fast forward now into current practice, or not. Can you go to the next slide? There we go. Keep going. So in 2023, I don't know why this stopped here. We go. There we go. Now we're adding a number of other things to our portal hypertension work. We're doing biliary endoscopy, adding to our biliary work. We're doing interventional oncology as an entire new subspecialty, dialysis access and AV fistula creation, musculoskeletal and pain is a totally new domain in interventional radiology since then, women's health, prostate embolization, PE intervention, and lymphatic interventions. And you can just see an incredible expansion that's happened over my career in interventional radiology. Another way to look at this is the expansion of IR-CPT codes. And over the last 20 years, IR-CPT codes have expanded from 369 to 811. And not only have the number of codes increased, but also the utilization of IR codes. And over the last decade, you can see there was a rapid increase in IR code utilization. From 2016, especially to 2019, we had a little dip in 2020 with the pandemic, but seeing a nice rebound after that. So how come we made it through the difficult times in the early to mid 2000s? I think there are 6 primary reasons why this happened. Number one is that we are very, very good at collaborating in multidisciplinary teams, and medicine is truly a team sport in the year 2023. We've learned to shift from trying to protect our turf to competing on the basis of quality and cost effectiveness. And after literally decades of talking about creating clinical infrastructure and taking care of our patients, we are all now finally doing this. I have received a couple of letters have been written to my chairman and the president of MCW by outside medical oncologists complaining that I stole their patients from them. And I realized that it's not a sustainable model to not send cancer patients back to their medical oncologist, but I urged them to do that, but they refused. And what can you do? But I believe if Dodder received those letters, he would frame them. Fourth, we are providing foundational services in a hospital setting that numerous programs depend on, such as trauma surgery and transplant surgery. As was mentioned earlier, we have a growing research infrastructure proving the data around our therapies, and we're running NIH-sponsored trials. We're in the NCCN guidelines. We're doing great work, and we have a lot more work to do, but we're making progress. And finally, at the end of the day, we all in this room have a valuable skill set that is unique, and it cannot be acquired with a weekend course. So now what do? We've survived and expanded rapidly. Can we keep up? I think it's going to be challenging because when you look at what's happening with medical knowledge, it's really amazing. So in 1950, the doubling time of medical knowledge was 50 years. In 1980, down to 7 years. 2010, 3.5 years, and it was estimated to be 73 days in the year 2020. That means that in this year alone, medical knowledge will double 5 or 6 times. Another way to look at this is that all of us, not only GPs, but everybody would need to read about 21 hours a day in order to keep up with the advances. So that means that even our esteemed JVIR editor, Dan Zay, and all the associate editors wake up every morning further behind in medical knowledge than they were the day before, no matter how many articles they reviewed and how many references they checked. The extreme pace of medical knowledge growth requires that we adapt how we train our residents and fellows. We may need to start teaching information management because keeping up with evidence-based medicine is becoming unrealistic. One obvious way to respond to this increasing pace of medical knowledge development is subspecialization, and the pros and cons of increasing medical subspecialization has been debated for years. The pros are the benefits to the public and patients of having clear standards for emerging areas of medical specialization, and the cons are further fragmentation of care and practical issues around certification and maintenance of certification. Now, I'm a little bit of a procrastinator, so I was a bit behind in getting this lecture together, and so I decided to ask ChatGPT whether subspecialization in medicine is good for patients. And the ChatGPT answer was subspecialization in medicine can be good for patients in some cases, but it depends on a variety of factors. And you can see there it goes on and on. At the end of the day, it sounds like a politician is responding, so I had to kind of do the work myself. Subspecialization has been occurring in surgery for decades, and the impact on general surgery has been to narrow its scope. At the end of the day, I think it's good for patients that the same physician who takes out a gallbladder one day isn't operating on someone's carotid the next day. And in some ways, we are probably seeing the beginnings of a similar trend in interventional radiology. As Parag mentioned earlier, we have now created 8 FSIR clinical specialty councils: neurointerventional, interventional oncology, renal GU, venous disease, pain management, MSK, peripheral arterial disease, women's health, and pediatric interventional radiology. This replaces the previous service line structure. And I want to just make sure we're all on the same page here. And when we talk about subspecialization, that's not interventional radiology. We are a primary specialty approved by the ABMS and the American Board of Radiology. A subspecialty example is interventional oncology, and subspecialization would be specializing in liver oncology, lung oncology, musculoskeletal oncology, etc. These are the criteria generally acknowledged by the American Board of Medical Specialties for subspecialty certification and recognition of focused practice. Represents a unique body of knowledge that cannot be fully incorporated into a parent discipline, has clinical applicability different from the parent discipline, is based on and contributes to the research base of medicine, offers evidence that the discipline improves patient care, requires supervision and direct observation in formal training settings, involves complex technology or site-specific care skills, and has a positive value for certification on the new discipline that outweighs any negative impact on the presence of the general practice. We are not currently seeking subspecialty certification for any of the IR subspecialties, but this could certainly occur in the future. So how do we provide the highest level of care to patients across all these domains? How do we collaborate or compete with other specialists who are more focused than we are? And how do IR practices navigate core interventional radiology versus subspecialization? These are difficult issues. I know when I go to tumor board and we're talking about a hepatocellular carcinoma patient, the amount of data that I have to know in order to adequately represent our therapies versus the other therapies that will be discussed at that tumor board is an unbelievable amount of knowledge, and it's getting larger every day. We not only have to know our own data, we have to know the systemic therapy data, the surgical data, and the radiation therapy data. And I think it's just impossible to have the depth that's needed to do that if we try to do everything in interventional radiology. But we have to find a balance. I think this is part of the normal evolution of IR. It's required for us to develop multidisciplinary relationships and attend focused tumor boards and conferences. And we have to balance professional satisfaction, the needs of our practicing group, and the call frequency and responsibilities when we figure out how to navigate these situations. In our practice, and we don't have all the answers certainly, we're struggling with some of these issues. Our core IR procedures are the things that we have to do on call, plus the daily on-demand services. And then we really try to subspecialize in the elective outpatient work, such as tumor ablation, radioembolization, limb salvage interventions, complex endografts, prostate embolization, lymphatic, and spine interventions. But every practice has to figure this out, and there's no roadmap for everybody. This is Roger's diffusion curve, and everybody in this room is on the left half of the curve. But again, I think it's important to state that subspecialists and experts are the ones that drive innovation, and this specialty is founded on innovation, so we have to enable this as we go forward. Now I'd just like to go on and say that I think we have to be a little bit careful of the shiny new penny phenomenon. Just because it's new doesn't mean it's the right thing to do. I hope in the future that we focus on problems, diseases, and patients with the greatest unmet needs, and keep in mind that the patient always comes first. And I think we have to have a little bit of humility and realize that we are not going to solve all the major health problems of mankind with catheters, but we are going to make an impact on many of them. So I want to give a couple examples of where we've expanded, one that went not so well, and one I think that is going quite well. And so hopefully many of you will remember, it wasn't that long ago when Paolo Zamboni proposed the theory of CCSVI as a major cause of multiple sclerosis, and that jugular vein angioplasty could alter the clinical course of multiple sclerosis. This was in 2009. And right after this, there was a media storm, both in social media and news media. They heralded this as liberation therapy for multiple sclerosis patients. And the multiple sclerosis patient population is a very sophisticated patient population. They're very involved in their care. And they took all this media storm and basically began to demand CCSVI therapies. Based on little or no evidence, many IR practices began to offer venous angioplasty and stenting for MS patients. A small number of centers designed and started to run clinical trials, and kudos to them. Many sessions and debates were held at FSIR and other major meetings, and there were outpatient centers that popped up all over the country that were catering specifically to this patient population. The fallout was that thousands of patients depleted their savings, traveled to clinics around the world for ineffective therapy, sometimes suffering significant complications. And it has been written that sociologists and medical ethicists will study the CCSVI controversy for many years to come. Not only did this have potential damaging effects on the patients themselves, but it also damaged oftentimes the relationship with their MS neurologists, creating additional issues with their care. As a result of this, in 2012, the FDA issued two extremely strongly worded warnings. The FDA is alerting people with MS to the risks of serious injury and death associated with procedures to treat CCSVI. Furthermore, the benefits of those experimental procedures have not been proven, and their promotion as a treatment of MS may lead people with the disease to make treatment decisions without being aware of the serious risks involved. And they went on to say that they believe that using medical devices in CCSVI treatment procedures poses a risk to patients because there is no clear diagnostic evidence that CCSVI exists. Venous stenosis seen on imaging tests may be normal variants. The safety and efficacy of using balloon angioplasty devices or stents in the internal jugular or azygous veins has not been established. There is no clear scientific evidence that the treatment of internal jugular or azygous vein stenosis is safe in MS patients, and it's possible that stent placement can make things worse. It can't be more clear than that. Zamboni, to his credit, later admitted that he was wrong and CCSVI was not a major factor in MS, and he published his own prospective randomized clinical trial, angioplasty versus sham, that did not show any clinical difference in the outcomes of MS patients who received the therapy. So I hope we learned a lesson from that. It wasn't that long ago. I think prostate artery embolization is an example of something that we're doing the right way, in the right order. In 2000, the first case report was published of prostate embolization for lower urinary tract obstruction. In 2011, the first case series, and in 2014, the first randomized clinical trial of prostate embolization versus TURP. And you can see here the amount of publications have been increasing year over year for many years, with a peak of 121 publications in 2020. And if you look at clinicaltrials.gov, there's 48 enrolling or completed clinical trials on prostate embolization, so good for us for doing the right thing. As a result of this, FSIR responded by creating a code specifically for prostate embolization, which was published in 2014. And in the Medicare patient population, the utilization of this code increased rapidly through 2017 and then dipped somewhat due to some reimbursement challenges. We had, of course, a lull during the pandemic, and we're seeing a rebound in 2021. So I think we did well, and hopefully we've learned our lesson about all expansion and isn't good expansion. What do we do next? I think it's important to enable the subspecialization to continue, and this may include doing subspecialty fellowships now that we have a residency. I think it would be natural for us to develop subspecialty fellowships in diseases like interventional oncology, peripheral arterial disease, MSK, and pain. And I think an area that we really need to do a lot of work is in research training. When I look around the room at Tumor Board and the other specialists that are there discussing these patients, they all have research training embedded in their residencies and fellowships. We do not so far. We need to develop research structure and research training in our residencies and our fellowships. We need to also pursue federal training grant for funding such as R38, R25, and KO8 awards, which I think, unfortunately, there's very few interventional radiology practices that have those awards ongoing right now. And I just, to wind up here, would like to say that I don't think specialization equals separation. I think there's a fear always that we're going to fragment this wonderful specialty that we all love so much. But we are all still interventional radiologists, and FSIR is our umbrella organization. We must enable subspecialists to succeed. The core work of advocacy, coding, and reimbursement and practice affairs cross all subspecialties, and FSIR does a phenomenal job helping us do that. It's been quite a journey, and I feel very lucky to be along for the ride. FSIR was born in 1964. We were a toddler in the 70s. We went through our childhood in the 80s. We were an awkward teenager in the 90s, but beginning to show our potential with really big feet. We went through an existential crisis in the 2000s. And then after that, we had a rapid expansion of IR practice in many domains over the last 20 years. And now I believe that we're hitting our prime. We must learn from our past and look to the future. So in summary, the expansion of IR practice over the last 20 years has created an embarrassment of riches. General medical knowledge and IR knowledge have grown exponentially, requiring subspecialization. Subspecialization is a part of the natural growth and evolution of our specialty. Future growth and expansion must be done methodically with stepwise evidence-based development, and training programs will need to continue to adapt to foster this evolution and keep pace with IR innovation. In 2005, many were predicting the demise of interventional radiology. We have survived and expanded greatly the number of patients who can benefit from our therapies. Charles' daughter would be proud. I don't have a crystal ball, but look around at the enormous talent and energy in this room and just imagine what we're going to do over the next 20 years. I'm so proud and fortunate to be part of this amazing community. Thank you very much.